Welcome, my name is Joy Gordon and I'm the Community Liaison for the NORC program. NORC stands for Nurturing Our Retired Citizens. This project is funded by the Administration on Aging and the Minnesota Department of Health and Human Services. The mission of the project is to help seniors remain in their homes and in their communities for as long as they can with the support that they need to be healthy, safe, and engaged citizens. As part of this mission, we bring you monthly health and wellness lectures on many topics of interest to seniors and their caregivers. The lectures are co-sponsored by the St. Louis Park Senior Program, the Hopkins Activity Center, and NORC. Our topic today is everything you need to know about arthritis. Our speaker today is Dr. James R. Larson, sports and orthopedic specialist. Dr. Larson is an orthopedic surgeon at Sports and Orthopedic Specialists, subspecializing in adult reconstructive and arthroscopic knee surgery. He has more than 26 years' experience and is the recipient of numerous awards, including being consistently voted as the top doc among Twin Cities orthopedic surgeons. In addition to his renowned practice, he is an avid golfer, master chef, and gardener. Please join me in welcoming Dr. James R. Larson.
Well, thank you so much for inviting me here today. This is really indeed a pleasure. And today we're going to talk about knee surgery. Now, right now I'm specializing more in knee, but over the years I've done all types of arthritis surgery. So if there's questions, we'll kind of address them as we go. So it's really indeed a pleasure, because this old feared enemy, the arthritis, is starting to attack everybody. Now, maybe it's just the aging population, but doesn't it seem that it seems to be more and more of an issue? And it's something we really need to get to the basic foundation of. Now, there's some things we can do, some with better understanding arthritis, but also understanding in the treatment and the prevention. What basically are we dealing with today? Today we're going to kind of hone in on the knee. Now, the knee is a very complex type thing. Now, when you're doing surgery, you'll notice that here everything is labeled, but in surgery nothing is labeled. You have to know what all these little bumps are as you're kind of going into it. When we're starting at the top, we have the femur bone. It comes down to the lower leg, which is the tibia bone. The menisci, or the cushions, are between the bones. They help get lubrication, gives cushion to the joint, and actually helps as a spacer, so the joint is evenly balanced for forces coming down as we weight bear. So all these things have to work together, really, for the knee to function. Now, what are we dealing with? Well, inside the joint of the knee, we have articular cartilage. Now, there's cartilage that covers the bone, that's articular cartilage, and there's meniscal cartilage that acts as the cushion. The articular cartilage, basically, as it covers the bone, it's very smooth. It's really 25 times slipperier than two ice cubes rubbing together. So functionally, it really does a good job. It's made out of fibrous tissue, and it does indeed cushion so that we can jump and we can do things, we can run, and we have to have some time to recover. But as we recover, we're back and ready to do it again. And this is all because the articular cartilage really functions well, especially when we're young. As we get older, it functions less well, so we need more time to rest, more time to get back into the activities. So what are we dealing with when we're talking about arthritis? Well, arthritis basically is any cause that changes the articular or the surface cartilage so it wears, gets thinner, gets very asymmetric, and so it develops really degenerative changes within that, which is just a wear pattern. You develop bone spurs. Bone spurs on the edge of the joint is just the body's way to try to stabilize the joint. It's not very functional, so it doesn't help us very much. And to take the bone spurs off, they'll come right back because we still have the degenerative changes, we still have the irritation in the joint itself. We will have the thickening of the fluid in the joint, so we do get swelling. The swelling basically is the fluid that helps lubricate, and as we get irritation of the joint for whatever reason, arthritis or whatever, there's more fluid produced, so we do get swelling. Now, to take that fluid off, unless you change the reason for the formation of the fluid will come right back. It really comes back in about 10 hours. So you get only a short relief unless you can change the environment that produced all that fluid. And what happens as the arthritis progresses? The spurs get bigger and we get larger and larger joints. We can see it in the fingers with arthritis, we can see it in knees, and it's obviously even in the hips, although we don't appreciate it as much. Rheumatoid arthritis is another type of arthritis, and this is more of an inherited arthritis. It's systemic, means that it's throughout the whole body. It's autoimmune, means it's your body reacting against itself. And it's a reaction to chronic inflammation or chronic irritation of that joint. Now, it can involve any joint, from the top of our jaws right down to the bottom of our toes. And as this chronic inflammation exists for any period of time, the articular, or that surface cartilage, is destroyed. And so with that, we don't have the cushion and we don't have the ability to recover, even for long periods of time. Now, rheumatoid arthritis really can affect all joints, and it's very common in the small joints. In the hands, we get deformity, we get deviation of the fingers, and this is a very classic picture for long-term rheumatoid arthritis. What are we dealing with when we talk about bone thinning? You hear about this so much. What is osteoporosis? Osteoporosis really means just porous bone or holes in the bone. And when you look at the bone, we normally have small holes, and that brings nutrition, brings stability. But as we become more osteoporotic, or as the bone becomes thinner, we have large holes, so the bone isn't strong enough to resist fracture. And with this, over a period of time, we can see it in things like our shape is different, our ability to stand erect is different, because the bones really don't withstand that force. Much more common in women over 65, but we have to remember too that historically there's still more women over 65 than men. So this may be somewhat of skewed, but it does seem to follow more of a female pattern. Back to arthritis, and here we're going to talk about knee arthritis. What is the basic arthritis that we're commonly talking about? It's the osteoarthritis. It's arthritis that's not passed on in families. It's from injury. It's from ongoing wear and tear of the joint. And now we'll get into that. Now, is arthritis prevalent? I mean, everybody has it. It seems like everybody has it. All our friends have it. All our neighbors have it. I have it. That's a heck of a thing. But is it prevalent? Yes. The CDC is people that really record all this. They say by 2020 we'll have the largest increase in number of new patients of any disease in the United States. So it's big now, but it's going to get bigger. Now, some of this will be the baby boomers coming through. Many of them want to be more and more inactive. And so it's going to be harder and harder to keep them active if arthritis is not controlled. The prevalence in the United States here, over 65, represents 12.4% of the population. So it's really significantly large. But it will be projected to be 22% by 2030. But it's the most frequently reported chronic condition in the elderly currently. Risk factors, there are risk factors, so we can identify them, so we can say that, yes, you are more at risk to have this. Family history, it does go along in families. Unfortunately, seems to be passed on by the mother, but it's definitely in families. Overweight, now the knee itself is really susceptible to overweight conditions. 1 pound of body weight is increased 4 times through the knee. So you can see how dramatically that changes the wear and tear through the knee as we gain weight. Obviously, age has a lot to do with it, and this is just the wear and tear situation that we see when we're dealing with arthritis. Female, again, much more common than male, and again, it is related to some prior injuries. The people that are injured will injure the cartilage. They'll have traumatic lesions, which are bumps and lumps and things. This can, over a period of time, result in changes in the surface cartilage that will result in arthritis. Signs and symptoms. Gradual onset, it isn't something that comes overnight. If it's something that comes overnight, you have to think of other things. I mean, that's also very concerning, but it tends to not be related to arthritis. Stiff, swollen joints, very common, because you're changing the surface cartilage, so you don't have the ability to hold the water in the joint, so the joints get very stiff. And obviously, with increased activities, we don't recover well because the surface is changed, so you do have increased pain. You can have locking and buckling of any joint, very common in the knee, because as you have wear, it doesn't match up very well. So the round surface doesn't match the flat surface very well. So it'll catch, it'll give, it won't support you, it'll give you that sensation. The joints that are affected, obviously many joints are infected. Spine, not uncommonly, we all have stiffness with the back and neck, very common. Hips, very common. What type of hip pain? Now, hip pain, people come in because they have buttock pain. Now that tends to not be hip pain. Hip pain tends to be more groin pain, more pain with certain positionings, inner thigh. Sometimes the pain will be referred from the hip to the knee, so they'll come in with knee pain, but it's actually referred from the hip. Very common. With the degeneration of the joint around the hip, you'll lose motion, so you'll have difficulty crossing your legs, difficulty getting in and out of cars. So it is kind of obvious when we listen to the symptoms. Other joints, knees, again, very common. They're always stiff, swollen, hard to walk, hard to get out of a chair, hard to get out of a bathtub. Low chairs are very bad. Low bathtubs are impossible. Commonly affected in the hands. Hands get stiff. Rheumatoid arthritis, classic deviation. Osteoarthritis tends to not deviate as much, but gets nodules or Heberden's nodes in the hands. So the Heberden nodes are bony little nodules that you get on the ends of your fingers in the last knuckle. Very common. And this is the villain that we're talking about. So we're going to kind of delve into this now, and we'll try to get into a little bit of the arthritis. So if we have questions along the way, be sure to ask. What treatment options do we have? Well, there are many. But unfortunately, sometimes they're not enough. Activity modification helps. We have to avoid the squatting. We have to avoid the impact loading. Obviously, we can't play tennis as frequently. We can't do jumping activities. Currently, with the use of the pools and these exercise programs, it's a wonderful thing for arthritic joints because you have very little forces that go through the joint. So it really preserves it and still preserves activities. You have to modify. Obviously, it's very helpful to have home and exercise programs. You need to maintain range of motion. As we get stiffer, it's critical to maintain range of motion. This will help your ability for gait and help your ability to get in and out of certain positions, whether it be a car or chair, and minimize the aggravating. That is, just listen to your joints. Your joints are telling you every day what you should and shouldn't do, but we rarely listen to it. Ice will help. Ice in the joint, heat in the muscle can be very helpful. If you suffered an injury, it's very helpful to alternate. Ice for 10 to 15 minutes and then short episode of heat can help and go back and forth. So all these things can help even though the process is going on. Weight control. Obviously, that's a touchy subject. We all have to be concerned about it, but we do appreciate that it has phenomenal effects on the joint. So if we can do that, we can decrease the forces of the joint and make it less painful. The types of foods that we eat, it probably has a lot to play in arthritis. We yet to really understand it, but there are certain things we watch, whether people talk about red meat or whatever. I mean, that we really don't understand very well, but I think this is something where the secret is going to come. Anti-inflammatory medications, well, there's so many on the market. I mean, you can go to Costco, Walgreens, and everybody has rows and rows of them. Well, they do function, they do well. They can be hard on your bodies. They're broken down in the liver and kidneys, and so you have to be concerned about how much you take. But on a certain flare-up, they can be very helpful. Decrease the pain by decreasing the inflammation. It won't hide pain, so if you're having pain for other reasons, other joint problems, you'll still have pain. What are the ones in the past? Well, in the past we've had a number of them. Over the counter we still have Motrin, Aleve, can be very helpful. They do irritate the stomach. They can cause bleeding because they'll thin out platelets, so we have to be very conscious and careful when we take it. But indeed, on an occasional basis, they can be very helpful. Now, the companies tell you that you really should take them on a regular basis so you get higher levels, but we really don't know that. So I recommend that people use it as they need it, be very careful with it, and be conscious that if you're having difficulties, irritation of the stomach, be sure to call your physician. Celebrex is one that is one of the few that's left. That's a COX-2. COX-2 means it doesn't affect the platelets or the bleeding, so we can use it even with past history of ulcers. Again, the other ones that were taken off the market, they had effects that we weren't aware of, such as affecting the kidney with causing high blood pressure and all these things. So it's still of concern, but on an infrequent basis, it appears that it's very safe. Glucosamine and chondroitin. Now, I take this myself. I took it for quite a while before I really noticed an improvement. And now I'll stop taking every now and then just so that I can see how the effects are. And it really takes the stiffness out of my fingers. It helps me get rid of my morning stiffness. If you look at the companies and how they do it, they say 80% of the people get some benefit. Now that's probably way too high. And we do know that it doesn't benefit people that don't have arthritis. So if you have relatively normal joints, both in function as well as in appearance, it probably will not improve or aid in any respect. But if you have arthritis, it is really, I think, a very valid thing to try. Now with this, you need a vitamin with it. You need selenium. And so one-a-day vitamin can be very helpful. And it will give you the anti-inflammatory result. So I do think that although we can't show the proof looking at x-rays, it doesn't regenerate the x-ray in appearance, so we don't see a thicker joint space. But we do know in the laboratory that the small cells are a little rounder, they're a little plumper, they appear to be a little healthier, so there is some function there. And we don't really know exactly where it is, but we do think that it balances out the synthesis or the creation and the degradation or the breakdown of the polyglycans, which are the cartilage cells that form the lattices that cover the joint.
Doctor,
Yes?
you said if you take it, you need to take a vitamin and selenium?
Selenium is in the vitamins, so any one-a-day vitamins. The question is, selenium, where is that found? Now that really is in all vitamins. And so if you take a one-a-day vitamin, you'll have all the nutrients that you need in addition to the glucosamine and chondroitin. Now, again, it's not mentioned by the FDA, so it's not protected by anybody, so you want to have a reputable dealer for this. And I don't know if it makes any difference. They're getting so elaborate that it probably doesn't matter very much. Now, I've taken a number of different kinds because I thought that I should be the guinea pig to try them out, and I really couldn't tell. I could tell it did help, and it didn't help if you didn't take it, but the type of the medication didn't seem to do it. But the big thing is you can't stop any of the other treatments. It's still important to continue the other medications. The other things is corticosteroid injections. Now, when people have flare-ups, cortisone can really be very helpful. Now, in the past, we discouraged frequent cortisone shots because they were crystals. The newer cortisones are liquid, so they're absorbed better. So we think that you have more chance that it's going to be absorbed over a period of time, and with repeated injections. We still like to discourage more frequently than every 5 to 6 months, but it's dependent upon the severity of the attack, but it can really be helpful, not necessarily in doing anything other than taking away inflammation. So if the pain is caused by other reasons, then it won't be very helpful. If the pain is referred from the hip and you get the injection in the knee, obviously it won't help very much. So it helps a little bit in the diagnosis too. So you know if it helps, it obviously is coming from the knee and not referred from some other area. Supartz, the new things. Now there are many on the market. This is a hyaluronic injectable material, and it's very thick. It's almost like an oil-like substance, and it's put in the joint, and you need to have a series. Either each one is a little bit different, but usually one a week for 3 weeks or up to 5 weeks, and it will help change the environment for the cartilage cells. So by doing that, hopefully you can improve the inflammation. Now it can last for even up to a year. It probably can be repeated. We don't have good information that repeating it on a second or third time, but we've had people that did so well with it, we repeated, and they did well the second time. So there is definitely room that it can be repeated, but long-term relief, it'll give only maybe 12 months, maybe a bit longer, and it really will only be in mild to moderate. Once you have bone changes, so the bone is narrow at the joint space, so you have bone on bone, then this type of product is not very helpful. So I encourage people, if you need it, the time to have it is earlier on when you're just forming the arthritic changes and you still have only mild to moderate arthritis. And the one that we do is Supartz, is very common. That's one a week for a 3-week period. It can relieve it right away, but it's not often immediate. Sometimes it takes even up to 3, 4, 5 weeks before you see relief. Some people get relief right away. It can surely last for several months, but rarely longer than a year. Arthroscopy. Arthroscopy, or that clean out, arthroscopy is where you take the small tube in surgery, look inside, and then clean the joint out from any debris or small fragments, it really doesn't help very much. And there's been very good studies showing that it probably doesn't help very much at all. So we really discourage this. Once you have arthritis forming, to do a washout or clean out has very limited benefit. So we really say the treatment now of arthritis, especially the bony arthritis seen in the knee, is not going to be a clean out. So what do we have to do? If the arthritis progresses, then we have to think about a joint replacement. I think at some point we'll be able to have lubricants and things that will fix to the bone, fix to the cartilage, and provide a better surface. But at this point, it's really not available. Now, when you're looking at arthroplasty, arthroplasty is just the plasty is the components that are put in. A uni is when the arthritis is only in one area of the bone. So a uni compartment or a single compartment arthroplasty, which you see right here. All the arthritis is just limited here. It's seldom that you see arthritis so limited to only one area of the bone. If someone has a fracture early on in their life, so they break just a small portion, it surely can result in arthritis in a limited area. Or if it's very early on, it surely can. But by and large, most people, when they have the arthritis and the swelling, it's already progressed to more than one compartment. So it's 1, 2, or 3 compartments, which would be tri-compartmental arthritis. And what are we talking about with a knee replacement? Well, obviously we need an incision, so we have to open the joint so we can see all the parts of the femur, tibia, and all the ligaments around, and we replace it with metal on the top, titanium on the bottom, and a plastic insert. Now the plastic insert is made out of a material that's high density polyethylene. It's much like plexiglass that they compress, heat, and then mold, and it's extremely slippery. The hard surface on the top is a stainless steel, which is so hard that you have to cut it with a diamond tip saw. The base plate, or titanium, is very flexible and very light, so it's flexible like bone. So it absorbs and shares all the forces like bone does through the joint. So it really is a very, very good situation what we've created here, and you can replace it with all these different implants, and it takes about a 2-hour procedure to accomplish it. The reasons why we have to think about total knee, well, we obviously have severe limitations in daily living, so it's a quality of life issue. Some people have bad x-rays that shows arthritis that is so severe, but their pain is not limiting. Well, that wouldn't necessarily be the one that we'd think of for a total knee replacement. But if it doesn't improve with any other treatment, that's the one that would be a candidate. And you have to evaluate on an individual basis, because the x-ray doesn't always determine the severity of the arthritis. Now what we're doing now is a minimum invasive procedure. Now this is really quite exciting. Now minimum invasive basically means we still have to make the incision, but the skin incision is smaller, so it's a smaller window that we look through, and it's reduced approximately 60%. So with that you have all kinds of benefit. The incision comes from the top of the kneecap or patella going down below where the patella attaches to the tibia bone. And the tissues are spread and the ligaments are moved out of the way but not cut. And so by doing that, there's less bleeding. You can actually lift your leg in rehab that day, actually. So people can even walk the day of surgery. So the long term, after a period of time, and it'll probably be 6 to 8 months, 12 months, a big incision or a small incision will have the same result. It'll be a cosmetic size, but the ligaments by that time will heal. But in the short term, those first several weeks through surgery, the recovery is much, much quicker. So I do think we do have some improvement with these minimal invasive procedures. We do have, the procedure can be a little bit longer, but with local blocks. We can do it with limited anesthesia. We have less blood loss because we don't cut the tendons and ligaments. We don't injure the soft tissue because they're all left, the envelope is all left intact. Postoperative pain is much better, so pain control is easier and people can get up and walk quicker. Risk of complications left because people get out of bed that day or the next day and they're ready to start walking. And the time to return to activities is much quicker on every parameter, much less swelling, much less wound issues, much less pain as you increase activities. Now the computer also is playing a role. Now I've done 50 total joints total knees with computers. And at this point, although it's an attractive concept, it really isn't sophisticated enough to improve what we're doing. So right now we're working on the parameters and the software to do this, because eventually it's going to improve our accuracy. Eventually we'll get this down. But at this point in time, it's not quite there. But with the numbers of the increase in procedures and the demand, I think this is going to be an exciting way in the future, not only for knees, but hips, ankles, and really unlimited to any aspect of surgery. And when the computer is doing the visualization, we should be able to make the incision smaller, that everything should improve. So it should be that next step when we get there. Now, when you're thinking about a total joint, there definitely are questions that you should ask. How long are you going to be in the hospital after? It's very important, obviously, for your planning. Do you need walkers or crutches after surgery? Much of this is determined a little bit with the therapist, so it takes a good team of both the patient, physician, nurses, and the therapist to do a good job. What medications you need after surgery? Will the stitches come out? Do you need stitches? Now, I don't have any stitches outside of the skin. I have a bonding agent that we put on, so we avoided the stapling or the sutures. So it's much easier. You can take a shower the next day and to avoid some of the problems in the healing process. How soon is therapy? Well, as soon as we can. So the next morning, for sure, we like people to walk, get out of bed, and start getting the range of motion, getting the knee motion back. Questions, when can I start driving? Well, it's limited a little bit right to left leg. Right leg obviously takes a little bit longer. You have to be a little bit more careful with that. But by and large, it's limited to when you can be off the pain medications. So as soon as you can be off the pain medications, you can start, doing the driving process. And the therapist helps us a lot, telling you whether you're at that point where you have good muscle control and you can proceed to driving. Disabled parking, I think we're lucky in Minnesota because we really have more access to disabled parking. And this is really what it's for. So I think people with arthritis, even after having a total knee replacement, this is what we really have. Now we have these at our office, so you just have to ask for them. We can mail them out. You just bring them in to where you get your license, and they will honor that. So that's really what we want. Now we have to remember that the car is not disabled. So putting a disabled sticker on a car doesn't mean that anybody that's driving that car can use that disabled parking. It is for the person that applied that is disabled for their use only. A dentist. Now this is really still important. Now when we have dental work, mostly with cleaning your teeth, you free up a lot of bacteria in the mouth. And so you need to have antibiotics at least for a year, and probably even for that second year. Other procedures, well, we do individually, so you should call, and then we can chat about it to see what you need. But definitely there are indications that we need antibiotics, because we see if you free this up, it will get in the bloodstream and it can infect the knee seemingly only early on. So within the first year, you're more at risk. This has been really a pleasure for me to come and chat with you today, and it's a topic really that's on everybody's mind. Thank you so much. Yes.
Thank you so much, Dr. Larson. This has been a very informative lecture. I've learned a great deal for sure.